Right, it looks on my computer as if the recording has started, so we're in a position to open the meeting. So welcome to this meeting of the Northumberland Primary Care Commissioning Committee. Welcome everybody. We have apologies for absence from Richard Blenny, Siobhan Brown, Claire Lynch and Paul Turner. Any declaration of conflicts of interest for this agenda from anyone? No, everybody happy with that. If anything comes up as we go through, just call out, thank you. And we are quorate because everybody else we're expecting is here. So if we then move on to the minutes of the last meeting, for the sake of timeliness, I'm not going to go through them page by page, but is there anything that anybody wants to raise, first of all, on accuracy? Karen, have you got a point there? Thanks.
Just on page 3, I thought it was me that raised the issue about the valence rather than yourself. Under the bold paragraph, the start of the next one, but maybe you said something as well, I don't know.
I think I did, so can we amend that to both of us, seeing it was a point both of us raised? Is everybody happy with that? Thanks very much. Thanks, Karen. Is there anything else for accuracy on those minutes? No, everybody content that they're signed off, thank you. And are there any matters arising from those minutes which are not picked up either in the action log or elsewhere on this agenda? No, everybody happy. That's good, thank you. We accept those. We then go on to the public action log. The first one is the valuation, the district valuation for Rothbury surgery, so that the breach can be taken off hold. As you will remember, this has been raised on every committee since the action was first identified in August 2020. The breach has been around since significantly before that, and I wish personally to express, and I suspect on behalf of the whole committee, significant disappointment that this is taking so long. And I know that this has been picked up from time to time, but it just seems that we get no further forward. And I think off the top of my head, this is something that's probably been going on for the best part of 3 years now, and I just find that unacceptable. So please, Will, whoever's picking this up, I know there's nobody on this at this committee who's personally responsible for this, but please, Will, whoever is tracing this up, express my, certainly, and from some of the nods on the screen, the rest of the committee's serious disappointment at how long this is taking. Obviously it is what it is, and unfortunately there isn't really anything else we can do because it appears it's from another organisation which is out of our hands. That takes us on to the next amber one, which is the estate strategy principles. It's in progress. Is everybody happy with that? Because we didn't fix a date for that, it was just when it was ready. And similarly, the next one, the development of standard operating procedures. This was obviously to be helpful to practices, and I see that's progressing. Is everybody happy with that? Thank you. And the only other one which is amber is Pamela, the recovery of practices, and provide an update. And I think you're working on this. I don't know if we have a date for that.
No, Janet, so I presented the findings from the GP recovery last time, and then we're just waiting for the data to be analysed and ready for a report, which will go to this committee and to CMB and other corporate committees within the CCG.
Good. Excellent. So we've already made some progress on that, and obviously that's still going, so that's good. So is everybody happy with the action log? Yeah, thank you very much. That takes us on to operational matters, starting 3.1 with the finance update. So over to you. Thank you, John.
Thank you. This is the finance report for month 6. You may remember that under the interim arrangements under which we're currently operating, the year has been divided into H1 and H2, so a first half and a second half. This is the end of the first half. I have to say the way the arrangements are set out and the way that they change between H1 and H2 don't particularly directly affect the primary care position, either in delegated or in other terms. But H1 here is ended, and we report that position in the report, and we're pretty much on that break-even plan, very close to it. The issues and various issues, variances underneath that have remained quite constant actually over the last few months, so I think we've probably discussed them all. In terms of H2, the arrangements for the whole CCG and the whole NHS are not too different actually from H1, and certainly in terms of this committee there's no substantial difference. I think what we will try and do from here on in, once we get to month 8, is we'll be reporting to try and report on a full year basis, because we're in a position now to be able to do that, and we can dispense with this H1 and H2 stuff. We can start to report on a full year basis, which will make us certainly feel a bit more comfortable. I think from a finance perspective, the rest of the year is quite low risk overall. I think there is enough money in the system to make things work. I think what is more of a challenge for us actually, and it is the performance issues that we face as the NHS, and how we spend money to effectively address those, given the whole kind of workforce issues and recruitment issues that we have. So I think that is far more of a challenge at the moment than making the money work. So I think from a financial perspective, low risk here. Other risks I think are really the longer term, although it's actually not that much longer term now, the establishment of the integrated care board and working across the ICS. And I would flag, I know, you know, we may have conversations about this later, but I would flag the kind of role of the primary care committee and what that looks like in the future now as one significant example of that. No one can tell me how that's expected to work, and you know, I think that is a risk which I would flag clearly when we look down the agenda today, both in public and private, when we've got significant decisions to make and an important business to do. So those two risks are more pressing for me than the finance risk. But other than that, I don't want to add anything else. Thanks, Janet.
Thanks very much, John. Questions and comments from members? I know this is fairly familiar territory because, as John says, there haven't been a lot of changes, and of course it's looked at in more detail along with all the rest of the financial performance at the Corporate Finance Committee. Karen?
It was just to say at the box at the top, it doesn't actually say what we're supposed to do with the report, so it maybe just need to amend that if the papers are on the website.
Yeah, I think you're right, Karen. I noticed that, and I think at the end it says we're asked to note. So yeah. I think the note
just needs the word note at the top.
The note has been missed off the top. Thanks. Yeah, in that case, I'll take it the member. Oh, sorry, Jane.
Thank you, Janet. John, I'm sorry if this is something which has passed me by, but it was just on your comment of the progress towards the ICS. Is there a timetable for the amalgamation of the various primary care budgets at place level, and what is the plans going forward in the timetable?
I have not seen something which sets out a timetable or a plan in level of detail as you described.
And is that a risk or an issue that this committee will be looking or overseeing in the next few months? That's because I say we're 4 months away from potential amalgamation, and I guess all the good work that's been done in Northumberland over the last 15 to 20 years to reach what looked a very healthy position by comparison with some previous years. It's just how we're going to really look out for our practitioners and practices.
Yeah, it's a really good question, and I wish I could answer it. I think there's still an awful lot of work to do on the ICB and ICS development in terms of, if I can just be fairly frank about it, in terms of bringing people up to a level of understanding about what primary care committees do, what CCGs do, and there needs to be, in my view, a much broader and deeper understanding of that across the people currently working within the ICB and the ICS.
But forgive me, Chair, I just feel it's something this committee should note, and in terms of certainly in terms of finance, it's taken an awful lot of hard work on behalf of many people to get to where we are.
Yeah, thanks, Jane. It's something that the committee is very mindful of, as you would imagine, and it is a major risk. And it's not just the finance. I think that this report, just to sum up the report before we move on, it's got really three elements of risk, hasn't it? There's the finance, which, as John says, is relatively low risk, although we note on page 6 the main pressure is still the contract changes, which have disadvantaged Northumberland, so that we have notionally, at least at the moment, well, it isn't notional, it's real, we have an accruing deficit on general practice each year because of the national contract changes, which we are covering at the moment. We were covering from our overall budget, and now, of course, because of the COVID arrangements, means that is in fact covered, but it means it's still there underneath. That needs to be addressed, and of course that's going to be going forward into the ICS. There's also the performance risks that John has referred to, which of course, generally speaking, are as a result of COVID, although we know there are always other winter pressures, but generally there are the COVID related performance challenges. But the ICS, ICB is a major risk, Jane, you're absolutely right, because we have, as things stand on our normal schedule at the moment, we have after this one more primary care commissioning committee meeting, and then after that we come to an end. And we have always said that the main thing we can now do, there are two things we can do. We can maintain performance to the best of our ability in the interests of patients, and we can manage an orderly handover to whatever the new structure will be. There is no new structure that we have been informed of as yet. So, we are doing everything we can. We're maintaining business as usual, but we are very conscious that our GPs at the moment do not know where their commissioning is going to go at the end of this. It's going to the ICS, obviously, in theory, but in an area as big as ours, with as many CCG areas coming together as ours, the biggest, I believe, in the country, we don't know what structure there will be at place to facilitate the sort of detailed work. And I'm sorry, I got onto my hobby horse, and I shouldn't really, because we're a bit tight for time, but we know that 90% of contact with medical services from the public is with general practice, and yet we don't know where the commissioning of those services is going to sit. And we have one more meeting coming up, so it is a real risk, and it's something we have as a standing item on our private agenda. But I don't think there's any harm in me saying on the public agenda, there is nothing to report on the private agenda because we still have no information on it. So it is a real risk, Jane. You're absolutely right. And please be assured we're monitoring it. There isn't really much more we can do. But I know there's a lot of lobbying going on behind the scenes to point out, as John says, I think that there's perhaps a lack of understanding of just what goes on at this level, and there's a lot of lobbying going on to say to people, look, you need a structure, you really need a structure for this to work. Sorry everybody, that's my phone ringing. I should have thrown it out of the room. Excuse me 1 minute, I'll put it out of the room. Plus it's still going on in the background because of the blooming answer machine. So yes, so I think those are the risks that we've identified going through that report, and I think our members happy that we've noted the position, and perhaps even more important, we've noted the risks, and we will continue to trace and monitor those risks as best we can. Okay, thank you very much indeed. I'm sorry it's not the best of news on that item, but it is a concern and we can't shy away from that. And that takes us on to the strategic section, on to item 3.2, which is the quarterly performance assurance report, which is headed by Robin Hudson. But I think, David, you're very kindly going to present this report this morning. Thanks. And David, we have got a fairly tight agenda as time goes on. So members have read the report. So if you would pick up some highlights and then we'll take questions. Thank you.
Right, thank you. I'll just spin through the slides very quickly then, and it's just outlining the sequence of events that has led to the review in terms of that. This highlights the areas of focus that Local Quality Group review the information, picking up both on soft intelligence and the quantitative data. And as well as sort of the performance side, we're obviously supporting GP practice experience, safeguarding, CQC inspections, and supporting the development of PCNs. And this just outlines some of the projects that the CCG is currently supporting. Based on the patient experience survey, some funding was made available to the CCG. A task and finish group has been established, and that's focusing both on patient and stakeholder engagement, as well as supporting practices to define the most appropriate access model going forward. Sustainability visits have continued, and that outlines the topics that are covered with each practice as we rotate through the year, going across all the practices. We now have a named nurse, which is a newly established role supporting practices, and the new post holders already visited 20 practices to date, and there are other visits planned to support families in multidisciplinary meetings. As I mentioned earlier on before, the development of primary care networks continues, and that outlines the topics that we're supporting the PCNs despite the pressures of the pandemic. As John referred to earlier on, workforce continues to be an area of focus, as does the importance of premises and releasing space, including the digitisation programme. And in the private part of the agenda, I'll go into more detail in terms of what we found in terms of the practice reviews. There were 5 practices in particular that we've had a particular focus on, but it's worthwhile highlighting that none of those practices demonstrated any area of clinical concern. 4 out of the 5 practices were within the same PCN, and we have Robin wrote to all the practices and we received responses back, and they've all responded very constructively. 2 of the practices are under significant pressure and are being supported by a neighbouring practice, but as I say, we'll go into a little more detail, but appreciative of the time pressures in the private agenda. So that concludes my overview, but Robin and I will be more than happy to answer any questions. But thank you very much, Janet.
Thank you, David. That's really helpful and very pleasing to see that the performance and sustainability work has continued despite the pandemic. I think that's very important for quality and for support. Robin, did you want to add something before we go to questions?
Yeah, I was just very briefly, Janet, just to back what David said. Practices are still under significant pressure. They are still engaging in the visiting programme, and that is an opportunity to flag where their concerns are. And it's multifaceted. It's staffing, it's blood bottles issue, its pressure of demand and on access. The 5 practices we wrote to have written back constructively. However, they have fed back the pressures that they feel, the additional pressure that they feel of not just doing a providing a safe service, but also responding to the quality group letters. And they have, despite that, they have responded constructively. And so I just wanted just to document, just to commend practices for the work that they're doing, and even those practices who we've written to commend them that they've actually engaged. They're still engaging with us, and they are So I just wanted to commend them to the PCCC.
Thanks very much, Robin. And when you're talking to the practices, would you also formally pass on the thanks of the PCCC for their cooperation, and emphasise that we do see these systems as supportive? They're not there to pick up poor practice or bad practice, though of course we hope they would if there was any of that, but they are there to pick up early warning signs and support and ensure that it doesn't lead to issues. So please do pass on our thanks, and I hope they do find it useful and not stressful. I've got questions first from David and then from Karen.
Thank you. Thanks for the report, which, bearing in mind Robin's comments, the report is pretty positive when you look at medicines management and childhood immunisations and so on, and cervical screening, learning and disability checks. We're all fine, and no significant safeguarding issues. But there's one area which does stand out a little bit, well, more than a little bit. That's the serious mental health annual checks, which is still about half where it should be in terms of the target, and within that there is significant variation. And I recall during Monday's ICS Health Inequality Summit or whatever, this very issue of serious mental health illness annual checks was raised quite significantly because of the consequent effects on physical health and well-being and so on. So I'm just wondering, is there anything which is being done to bring up those practices which seem to be even further behind the national target?
Yes, the practices, the outlying practices are continuing to be supported, and SMI health checks are now part of the PCCS incentive scheme, and sort of the mental health clinical lead has developed some training sessions to support practices into how they can actually progress the SMI health checks. So I expect the performance to improve going forward. But with that said, sort of the number outstanding does vary from practice to practice, and it has been the case that it is a rolling 12-month performance. So a lot of the time that the data capture will have covered would have been when a lot of the people concerned will be in the high risk group, so they will be reluctant to go out anyway. So that's why, and sort of Pamela and her team, we're all working on a recovery programme to map the way forward in terms of recovery. So when I report next time, I would expect once we've had sort of the impact of more recent focus work, that performance to improve.
Thanks, David. And David, you'll see that the final paragraph on page 8 does say that they expect to achieve the 60% target by the end of the financial year. So obviously we'll look at that at the next meeting to see that it's well on the way to that.
Yeah. Okay, thank you.
Thanks. Karen?
It was just a couple of comments, not a question really. One was just reiterating what you've said about commending both the CCG and the GPs, I think, that they've continued to manage to have those sustainability visits. I think it's a massive achievement, really, given the circumstances that we're in. The other thing I wanted to just say, it's not really in this report, but it was from another meeting that we had last week or week before, the appointment of the named nurse for primary care. seems to be having a very positive impact to date in terms of safeguarding, and I just thought that the committee maybe don't all know that that's in place, but that seems to be a really good move, I think, that we've put in. So that's it.
Thanks very much, Karen. And perhaps, David, you pass that comment back.
Certainly.
The named nurse. It looks like good progress as far as the committee is concerned. Thank you. In that case, everybody happy that we've considered and provided comment on that?
Janet, I think Annie's got her hand up at the moment.
Oh, sorry, Annie, I didn't see. Yes, you're at the moment. You've changed from a photograph to a button, and I didn't notice. Apologies.
All right, don't worry. Thank you very much, Jenna. I just want to point out for completeness as well. We have also another role is a practice link nurse. This role is fairly new and also play a role in terms of supporting practices, particularly in relation to delivery of the nursing services and also in terms of supporting the learners. So just want to add to the discussion. So in a wider sense, we also have other people that are working together with the primary care team in relation to that.
That's excellent. Thanks, Annie. The more support, the better. Thank you. David, did you want to come back in?
Just very, very quickly, if I may, in the patient experience sections and the primary care network sessions, engagement figures quite significantly. Might I ask how effective is liaison with patient participation groups across the county in terms of engagement about GP work? Does anybody know? Is it patchy? Is it or what?
Hi, David. I'll take that question if you like. So the comms and engagement team and the engagement team specifically have a full programme of work linking to patient participation groups. They have a toolkit for practices they're working on, and they have several forums. We've targeted certain practices who've expressed some challenges with engaging with PPGs. So there is a full programme of work ongoing, and the access programme as well. We are linking with PPGs as one of the sources of alignment directly to patients. Yeah. And I know, sorry, Emma's on the call as well from our engagement team, who might have more information on that.
Yeah, okay, thank you.
Emma, you've got your hand up, thanks.
Yeah, I just thought it might be helpful if I come in there as well. Yeah, thank you for that, Pamela. Just to reiterate what she was saying, that, yeah, we have got a full programme of work that we're doing, and we're making sure that PPGs are fully involved in this process. And I think it might be helpful for you to know that Derry sits on a group that we have where we are trying to establish a kind of engagement forum or it's a kind of a framework. We haven't quite decided on the name because it's a working group which Derry does sit on to make sure that we've got a route in for PPGs to make sure that their voice is heard.
Thanks very much, Emma. And Annie, did you want to come?
Yeah, just finally, just to confirm, really, David will know about it anyway. The Health Watch report is a standing agenda item on our quality and safety group. Obviously, Health Watch also share with us a lot of feedback from patients in relation to primary care services. And we use the quality and safety group to make sure those are linking with the local quality group that David Lee was talking about earlier in the report. So make sure that we sort of got some cross references. So while we not explicitly probably mentioned in the report, just let you know that again we're drawing on a wide range of patient experience indicators to inform the assessment and the support of our practices.
Thanks, Annie. That's very helpful. In that case, I think everybody's happy we've considered and provided comment. Thank you very much. Thanks, David and Robin. That takes us on to section 4, which is the strategic section. And we have a Winter Access Fund presentation from Pamela. Thanks.
Thanks, Janet. Just finding my buttons. I'll share my screen and the presentation, which I'll whiz through and take questions at the end if anyone has any. Just let me know if you can see that screen.
Yes, I've got it. Thanks, Pamela.
And I'll try and turn it into a slideshow. Yeah, now I can't see any of you because of the way this technology works, but I'll just go through the slides. So what I'm presenting today is an update to the committee on the focus on winter. access to general practice for patients, and also some latest guidance on expanding the capacity across the winter and the next steps of the vaccination programme, which we've had in the last week from the Jcbi, which is the Joint Committee of Vaccine and Immunisations. So 2 elements of national guidance. In October, we received a letter from NHS England outlining our plan for improving access for patients and supporting general practice over the winter months, which is up to and including Easter into April. So it's saying 5 months, November to March. We've added Easter in there because it's always an added pressure at the end of winter that we focus on. And that is to help patients with urgent care needs to be seen at their local practices in primary care instead of going to hospital. And the Jcbi guidance is in response of the emergence of the Omicron variant of the COVID-19 virus and the acceleration of the programme and offer to patients. So the Winter Access Fund has 2 main uses. It's to drive improved access to urgent same-day primary care, ideally from a patient's own general practice or across PCNs at a local level. And it also has a focus on increasing the resilience of urgent care system during winter and the interface that has in the community with primary care and community service providers. So the Winter Access Fund has some minimum requirements and areas of focus. There's been a lot of press, and I think there's been a lot of anxiety within the public around access to healthcare. And there is also a zero tolerance of abuse, as these anxieties can result in frustrations, which are understood with the population, but it's also balancing that with the demands we have in our system on our service providers. So with this fund, we must ensure all practices achieve at least pre-pandemic activity levels in their offer of access for patients. They increase the overall appointment volumes in general practice and maximising all of the workforce to do that. They increase the proportion of face-to-face appointments where that's deemed clinically appropriate in practices. And we minimise 111 calls in hours and avoid A&E attendances. And we support all practices by December to sign up and make use of the community pharmacy consultation service, which is a service for minor ailments and illnesses, which pharmacies are now providing with a number of, nearly all of our practices in Northumberland, and which we're continuing to develop. So there is a national data set which has been used to inform the planning of the use of the funding. The data set has got some issues, which I think we find with all data sets when you try to cross-reference a number of sources of data. But what this has done has allowed us with NHS England just to identify some practices who may need some enhanced support, and also focus on some ICS level and county-wide cross-CCG plans of delivery. So the work in the planning for use of the Winter Access Fund has been split into 3 levels of investment. And the CCG is also working really well with practices who are all fully engaged in addressing the variation in access to practices, making sure we can deliver equity of access, but also driving up the quality, and we manage demand appropriately and prioritise the care where it's needed. So the 3 elements of funding, there's some ICS level projects, which includes a flexible work pool. This is a digital solution which we've been asked to have in place by December, and it's a way of sharing available workforce across our practices and tapping into some additional help and support over the winter months. There's patient communication and engagement, and part of that is to ensure what we have put in, we can reflect, review and understand the impact and the benefits that that has had. There's also a pot of funding for additional admin and management support for practices, as the main projects have been focused on clinical staff and clinical areas of delivery. We've got some Northumberland-wide projects, so we've got some funding to implement some community spirometry services, which, given the COVID, the pandemic, the virus, respiratory illnesses and monitoring of those has been challenging. for the safety risks associated with that. So we are now looking at how we can implement some services to support that across the communities in Northumberland. We've also got an area of focus on in-hours overflow capacity and extended access, and that in the main is to increase the appointments available both in hours and in the evenings and weekends for patients. In addition, we've got some practice level resource that's been allocated. So we had 3 practices in Northumberland identified who are going through some challenging times, what with workforce, staff leaving, you know, mergers, changes to premises, a number of things. So we've got 3 going through enhanced support, and then there's some targeted investment for all practices in addition. That funding's focused on additional capacity, that's workforce for appointments, how it interfaces with 111 in general practice, and some digital equipment and some premises improvements to create some space for all of this additional work that needs to be done to catch up from the pandemic and through winter. So just a bit of an outline on the Jcbi guidance. We got this on the 3rd of December. So this is an extended offer based on the review of the new variant, and it's the expansion of the vaccine eligibility and the change to the offer in descending age, as we did last winter, and prioritising those most need from a clinical perspective with immunosuppressed individuals, and how we then, as alongside that, NHS England from a national perspective had looked at the contracts, the delivery, the conflicting priorities on general practice, and how we support the capacity to deliver this enhanced vaccine offer on top of the current challenges we already face. So increasing capacity, there will be a suspension and income protection on the minor surgery DES, so practices are being asked to consider how they pause some of that work and postpone. Where clinically appropriate, reschedule the 75-year health checks, the routine health checks. The quality and outcomes framework, some areas of this have been paused, however there remains the vaccination focus, the screening, and those patients on the long-term conditions registers, as well as optimal prescribing, which obviously David referenced as positive areas of focus in the quality report. QOF will recommence in full, which is the quality outcome framework, from April, and practices must submit a plan as to how they will prioritise those patients at clinical risk and account for health inequalities. And what I must stress in this is, in discussion with practices across Northumberland, they're all concerned about, you know, pauses on monitoring as well as delivering a vaccine programme. So this is very much at the forefront of their minds, and they are working to ensure those patients who haven't maybe had monitoring as recently as they should have done, that will be picked up and that will be prioritised as part of this work. So I'll leave that there and I'll take any questions.
Thanks very much, Pamela. I'll just give you a moment while that comes off the screen so you can see what's going on. Thanks. Questions and comments for Pamela from anyone? Thank you. Everybody happy with what we've seen, and it certainly seems reasonably comprehensive at the moment, and I'm guessing probably Pamela will get some sort of update at the next meeting. Yeah, good, just to see how it's all going. Thank you very much. Excellent, thank you very much. That's for information. Thank you. That then takes us on to item 5, which is any other business. I haven't been notified of any, so nobody's sticking a hand up, so we'll move on from that. Thank you. And the date and time of the next meeting, which is Wednesday, the 9th of February at 10 o'clock. It's quite frightening, really, to think that we're well into the new year by then. So we'll see everybody then. So in that case, that concludes the public business of the committee. So thank you for your attendance, everybody. And I'll wait for a moment while Barbara or whoever stops the recording. Thank you.